I would like to thank Paul and the organizers for inviting me to speak today. They've given me the task of talking about innovations that created the left atrial appendage therapy space. I think this is a very important space, and it's going to be much, much bigger than TAVR or even the mitral valve or tricuspid therapies. So I'm going to take you on a journey of how this came by. I have no disclosures for this talk. Therapies to obliterate, exclude, or occlude the appendage are now fairly well established. We do know that the benefits have been proven in clinical trials and even in real-world scenarios. All devices that occlude the left atrial appendage have the same purpose, but were designed and developed differently. How did they evolve? I think the first thing to know about this is to identify that the left atrial appendage was very, very early identified as a source of thrombus. In a very seminal paper by Dr. Blackshear at the Mayo Clinic, he looked at patients with valvular and non-valvular atrial fibrillation and also with concomitant mitral stenosis, and he found that left atrial appendage was the site of thrombus in about 90% of patients with non-valvular atrial fibrillation. Prior to this, it was a mixed bag. So pinpointing the left atrial appendage as the site of thrombus for this very important patient population was quite elegant. The other thing to know is the role of imaging. I think imaging is everything. TE still plays a major role in how we evaluate our patients and how we deliver therapies. I think in 1986, Ashberg and colleagues reported detection of a left atrial thrombus using TE, and with improvements in TE imaging, we had a better understanding of the left atrial appendage. So in 93, there was a paper that looked at the usefulness of multiplanar TE for imaging the left atrial appendage. I think this opened up the space for further device innovations. Now, like with a lot of what we do in interventional cardiology, we usually have surgical therapies ahead of us. I think that Madden in 1949 treated 2 patients with mitral stenosis and atrial fibrillation. They figured that these patients had emboli, not strokes, but peripheral emboli, and they took them to the OR, opened up the chest, did cardiac massage, and ligated the left atrial appendage. 1 patient died, 1 survived. So that led to a field where the surgeons started looking at ligating the left atrial appendage. This could be done with several approaches, open, thoracoscopic, and approaches. Now, you could use a suture, staple, excision, or clip techniques. We know that sutures, staples, and excision have their limitations in the sense that they don't always occlude the appendage completely. And we also know that the artery clip or the clip technique has been very good in demonstrating efficacy. So the surgical left atrial appendage occlusion was definitely an important step in innovation in this field. The LAA study was the first to document that surgery could be very favorable in these patients. When we talk about endovascular techniques, the first device on the market was a Plato device developed by Dr. Michael Lesh. At that time, I was looking at atrial fibrillation, but he patented this device in 1998. It was a self-expanding balloon-shaped night knot cage with device with multiple struts that produce an outward force, ranging from 15 to 32 millimeters in diameter, and had a PTFE membrane. Now, stabilization was achieved by 3 rows of small anchors. It was a 12 French delivery system, and it could be repositioned, retrieved, and recaptured. These are the same things that we do nowadays. We can reposition, we can retrieve, and recapture our devices. So these very, very early fundamental concepts still remain today. There was a series of studies, which was called the Plato study. This was one of the outcomes at 5 years, published by Dr. Block at that time, and it showed efficacy. There was a reduction in stroke rates from 6.6% to 3.8%. So there was definitely efficacy with this device. Unfortunately, the device was taken off the market for financial reasons, so it never really made it to the market. I think they didn't have enough money to do a large-scale randomized clinical trial. Following the Plato device was the Amplatzer left atrial appendage occlusion device. It was quite an interesting story. Benny Meyer and Kurt Amplatz in 2002 looked at this. The Amplatz ASO occluder was being used for an ASD closure. And during the delivery of the device in the left atrium, the disc of the ASO device actually popped into the left atrial appendage. So they figured, well, if we can actually put this into the left atrial appendage, this might be some form of therapy for the appendage occlusion. So the first in man was done in 2002 in Bern, Switzerland, and they did a series using a pacifier technique. So they used an ASO occluder to occlude the left atrial appendage. But it was limited by several things. Number one, they had a high 10% embolization rate because it was designed for the left atrial appendage. The mold of the device was inappropriate. This was an ASO device being used in the left atrial appendage. And the introducer sheath needed a distal curve to fit into the left atrial appendage. So it was quite cumbersome. They tried other devices on the market. None of them really worked. Amplatzer at that time, he was at that time retired, but developed a 2x45-degree out-of-plane sheath to help with this. That led to the development of the Amplatzer cardiac plug, which was now a dedicated left atrial appendage occlusion device. It was self-expanding, a nitinol polyester patch. It was a double device with a lobe crowned by hooks and a proximal disc. And it came in 8 different sizes. And this was quite useful for occluding the left atrial appendage, but it had its own limitations too. So based on that, they developed the current generation of what we call the Amplatzer AMOLED device, which had a larger lobe with more hooks and came preloaded. And the connector to the LA disc was recessed, so to reduce the risk of thrombus adhesion to that portion of the device. And they also redesigned the pusher cable at the end of the device. So this is the current generation of the AMOLED device, which is been shown to be efficacious in clinical trials and real-world scenarios. The Watchman device came along in 2000, developed by interventional cardiologists and engineers at Atritech. Early designs were obviously very difficult, but they evolved over time. They wanted to have an open-ended distal design with a semi-permeable fabric to enable the device to accommodate a wider range of sizes and left atrial appendage anatomies. As you can see here, this is described as parachute, jellyfish, whatever you want to call it, but it's got a 160 micron membrane with anchors that hook onto the left atrial appendage wall. It's nitinol, and it's got a large proximal face. This has also evolved now what we call the Watchman Flx, which is currently in clinical trials. Now we're going to replace the open distal face with a closed face, a shorter device length, and this is supposed to be easier to deploy and hopefully treat bigger and wider anatomies. So I think the Watchman Flx will be another iteration of the Watchman device that will make it easier to use these devices in the near future. I think the most important innovation of the Watchman is actually the amount of trials that we've seen from the device. I think the Watchman device has opened up this space with a fair amount of randomized and non-randomized clinical trials, and that's led to approval by the FDA. I think if you want to pick anything in the left atrial appendage space, the Watchman has led the way in terms of trial design and achievement of efficacy. I'll mention a LAA device here. This is the only suture-based device therapy on the market currently. We know it has 3 components: an occlusion balloon, a magnet tip wires, and a 12 French suture delivery device. We know it requires 2 accesses, a dry pericardial access and a transeptal access, and mimics the surgical suture closure. Future devices on the market will include the Corix Wavecrest device, Occlutech, Cardia, and LifeTech, and there are other devices on the market being tested. But the design concepts are quite similar. A lot of them involve nitinol, they involve membranes, they involve hooks and big sheaths. And retrievability and repositioning is essential. Hooks, wires, patches, various sizes, and sheaths are essential parts of a working LAA occluder, and that's what we do. This is a summary of where we've been and where we've come from identification of left atrial appendage as a site of clot in most patients with non-valvular atrial fibrillation, to surgical closures in the 90s, to Plato, occluder device, to the Amplatzer and the Watchman. I think the future is quite bright. So in summary, I'll say that the evolution of the left-atrial occluder space has been fascinating. The device continues to evolve as we search for the perfect occluder device. The space is poised to continue to be exciting and innovative for many years to come. Thank you.